got two hats. She's the head of chair of staff governance, and shortly to become chair of the IJB as well. Sarah. Thanks.
Yeah, all the best hats. So it was just a really small thing on, I think it was on page 76 of the report. It talks about the place that's been discussed, and it just maybe wasn't clear in the paper, so to give the board some reassurance. We obviously have discussed this quite extensively at our staff governance committee meetings as well, and at our last staff governance meeting earlier this month, we agreed to add whistleblowing to one of our standing agenda items, which I'll pick up later on when we get to the committee work plan, because I'm not sure we've updated that, but it was just to let people know that we've agreed it'll be on every agenda until such a time that we decide it doesn't need to be, but I don't think that'll ever be the case. So we've got that on there now. Thanks.
Thank you, Sarah. Any other contributions, comments, questions? Anne?
So I had a couple of questions. Just first of all, I just wondered, you know, I mean, obviously I accept that it was going to be a very big challenge for us to be absolutely ready for all of this by the 1st of April, Fiona, for all sorts of very understandable reasons. But I wondered if you could give us a sense of how we compare in our state of readiness with other NHS boards, you know, and also I'd be interested to hear a little bit more about how we plan to consult with the various organisations that are in the stakeholder category who provide services on our behalf, so that we can ensure that the processes are suitable and working well in due course when we've undertaken that consultation and extended the processes to them. So I'm thinking particularly, for example, you know, of our third sector organisations who maybe employ a lot of volunteers and will find this a challenge, but also obviously GP colleagues, etc., etc. And I just wanted to add, I think that it's been a great addition to our board to have Bert with us with this specific role, and I think that you know, especially in recent weeks when we've been able to benefit from the feedback that he's gathering through his activities, and I think that's really adding you know, an added richness to our conversations around our culture and speaking up. So I just wanted to acknowledge that. I think that's really important. Thank you.
You're on mute, Boyd.
Oh, sorry. Thank you, Fiona. I think that was a good introduction from Anne to Bert, a good handover there.
Thank you, Chair. Thank you, Fiona, for your input, and thank you, Anne, for your kind remarks. I suppose I'm speaking not only as a non-executive director, but also specifically in my role as the whistleblowing champion. I think the national whistleblowing standards are a hugely important development to give staff the confidence to come forward and raise concerns which are in the public interest, and know that they will be supported in doing that, and that there will be no detriment in doing so. And of course, there is an absolute inextricable link between the national standards, the whistleblowing standards, and the culture work that we've just been talking about earlier on in this meeting. And a lot of my work that I've been doing thus far has been straddling these two strands of work. The paper, and indeed Fiona's input, has explained where we are with the implementation, and indeed Anne mentioned a couple of things that I was going to be raising as well. So some elements of the standards will not be in place for the 1st of April. We know that. This is not unique to NHS Highland, and indeed there's been national discussion about this with the INWO. But I think I think the board would welcome some sort of assurance that we have a plan in place to take forward the outstanding elements. So I think that would be helpful for the board to get that assurance. And I mean, I'm aware of certain aspects that are underway. For example, the training of staff needs to be undertaken, and that is a big undertaking in terms of the commitment of time by people who are already very, very busy. And I suppose the bit that Anne was particularly talking about is in relation to the other stakeholders. For example, the IJB, the Health and Social Care Partnership, higher education institutes, contractors who provide a service to the NHS, and indeed volunteers. So I think it'd be useful, Fiona, just to have some sort of assurance about where we are with that. And I suppose particularly what I'm thinking about is that come the 1st of April, when the standards are implemented, that there is a process in place for everyone, whether they're part of the NHS or they're one of these external stakeholders, to be able to raise a concern, to know how to raise a concern, to have that recorded, and for all of the follow-up that is necessary thereafter to actually take place. I'm aware, and indeed the paper talks about the communication plan, which I think is quite a comprehensive communication plan. And of course that will incorporate the whistleblowing standards. But one thing that I'm not entirely clear on is, does that communication plan extend to these other stakeholders that we've been referring to? So how do these other stakeholders know about the implementation of the standards? Now, I think we would have some confidence in saying that the IJB, the Health and Social Care Partnerships, are aware of that. But I do wonder about other elements. I'm thinking particularly about volunteers. I'm thinking about higher education institutes, and indeed, I suppose, some of the contractors who are providing an NHS service. You mentioned, Fiona, about the Guardian Service providing the confidential contacts. And I think that's absolutely right. They are an organisation which is comfortable with working with NHS Highland, know the processes, they know the procedures, and indeed staff will know of the Guardian Service. I do, however, wonder about whether it is worth considering extending the availability of confidential contacts to members of staff within the organisation, individuals who may have something to offer in relation to that, or indeed who want to offer something in relation to that, and how we deal with that if the position is no, we're just going to confine it to the Guardian Service. I wonder also if there's a need for anything being on the risk register, because we are not fully compliant. So whilst that's accepted by the INWO, and as I said already, is the position right across Scotland, do we need to be thinking about anything on the risk register? And finally, I suppose, just an assurance that we have a process in place for the quarterly reports to the board, the first of which I would think would be due the beginning of July, which should be a report that, of course, is not only about raw data, about numbers, but it's also about trends, pockets of concern, and steps being taken to learn, to implement learning, and to sustain the learning. So that's all I've really got to say just now. So it's a mixture of comments and questions, and I'll pause. Thank you.
There's been quite a lot raised there in the course of these two contributions, Fiona, so I think I'll give you a chance to respond to them.
Thank you. I've been frantically typing to make sure I didn't miss anything. So, yes, I think going back to Anne's point, it absolutely is a big challenge. In fact, I think it was only at the end of last week. It's been quite a long couple of weeks, but myself and Bert and Gay Boyd actually had a conversation with the INWO office, really just to talk them through our approach, because obviously the Guardian service particularly is unique in Scotland, NHS Highland, in us having our own independent speak up service that's external to the organisation. So we were kind of, I guess, making them comfortable to some extent with understanding the role of the Guardian service and how they are going to support us with the whistleblowing standards, but also making it very clear that this is around confidential contacts, reporting, and being able to manage the process based on what the Guardian service have already got set up. But that absolutely does not remove the fact that ultimately it is the organisation who will decide if something is a whistleblowing concern and will investigate it and determine it. So it's probably important just to keep reiterating those two different roles. In terms of the comments that have been made around the broad remit of the standards and the fact that they do require us to engage and provide this route for whistleblowing concerns to third parties, independent contractors, care homes, GPs, etc. There's a number of ways in which we're working through that. We have an implementation group that is set up and meeting at the moment weekly. And we have an action plan that is being worked through there. We have representation on that group from our colleagues in the IJB, in the Health and Social Care Partnership. We also have representation from primary care. We also have representation from estates and procurement, and that's really important because in some of those smaller areas where we have people delivering services for us, it's through the management of the contracts for those services that we'll be able to promote what the whistleblowing standards are and for people to explain that to colleagues. One of the things that makes it a bit simpler for us in terms of, I guess, whilst not having fully completed that communication and engagement, and that is part of our plan, and it will be ongoing through April and May for us to really reach out also through, I think we said, our volunteer manager. The way that we will deliver this is that the Guardian service have set up a specific whistleblowing line for us. That's the point, irrespective of whether you work for the organisation or you're one of these third parties, you will be able to report your concern through that dedicated number. And that is really helpful for us because it gives us a sort of single point of contact for people to make that initial kind of contact. And so that's something that we can promote as well as the broader remit of the standards. I think in terms of the elements that are still being put in place, we're fortunate in that the training for the standards is delivered through the TURAS Learn portal online, and so there is a core 1 hour module that we've already started promoting to staff and encouraging them to complete. There is a more detailed one for managers, which but it's really around managers who would be investigating concerns, and the nature of whistleblowing concerns means that our sort of infrastructure for investigating concerns once they've been raised, it would be at a relatively senior level in the organisation and have a sort of core of individuals who can carry that out. In terms of the Guardian service and the sort of role they play, I say the data and reporting is something that we're engaging with them on, and part of their role is to help us manage that. And again, it's about building on the established mechanisms we've got in place. The Guardians, in their role as our independent kind of concern helpline. We get monthly reports from them with a lot of data about the concerns, how many are open, how many are closed, how many contacts have we had, what areas. So the Guardian Service is ideally placed for us to enhance and develop that reporting that's not just about numbers, but also gives us bigger insights. And it also allows us to combine the data about non-whistleblowing concerns with whistleblowing concerns and ensure that we don't lose anything, because obviously the whistleblowing definition is very specific about being in the public interest, and there are a number of tests. But actually what we wouldn't want to happen is that if somebody raises something, it's really important that that doesn't get lost if it doesn't tick the box of being a whistleblowing concern, because if actually somebody feels concerned about it, we want to make sure that we've addressed that. The point around confidential contacts is quite important, and I think at this point in time it's probably quite important that from a whistleblowing perspective that we've got a sort of single source of that kind of confidential contact. But actually whistleblowing concerns can and will be raised with managers, with HR, with staff side, etc. So there's a much broader role, and outside just whistleblowing, we're looking at rolling out some of the Civility Saves Lives initiatives, particularly around the calling it out with compassion, people working in peer support networks and being second messengers, and that's a really important part more broadly in the organisation for giving people who want to play a role in their local team about being, somebody that people can talk to and somebody that can advocate for them or listen to them. Is a really key part of our culture, and as we get a bit more familiar with the standards and the other kind of concern raising routes, it's definitely something we'll want to think about, is how can we ensure that if people do have an interest in being part of the support system, that we absolutely find the right way for them to be able to do that and give them the necessary training and support, because the two have to go hand in hand, and what we need to make sure is that if people become a point of contact, that actually that doesn't impact on them as well. So there's a lot to think about there. With regard to the risk register, yes, I think we are obviously as a board currently reviewing our top level risks and trying to make sure that we've got a balance of having our operational risks being clearly managed at the operational level, and then understanding, linked to our strategies and our priorities, what are the key board level risks we face. And so finding the right kind of place for this on the right risk register is absolutely right. And it may be that we look at a broader risk that kind of breaks down some of our key statutory level risks kind of holistically, because ultimately I guess what we're referring to here is that this is a statutory requirement that's being placed on us from the 1st of April. So we will take that forward. Hopefully I haven't missed anything on that list, but I'm happy to be reminded of anything I didn't cover. Oh, you're on mute, Boyd.
Thanks, Fiona. You'll get a chance in a couple of minutes because there's another three contributors wanted to come in. Alex, Jean, and then Margaret.
Thanks, Boyd. Yeah, Fiona, building on a couple of things that A, to your response, and B, what Bert said. On the top of page 77, the fat paragraph, you're actually saying, and when I read it, I've read it 3 times and I've got 3 different answers. We would expect these elements to be fully in place by 31st of July. Is that we are compliant with the standards by the 31st of July, or we've done the training by the 31st of July, or we've done the third-party awareness by the 31st of July? So what is it? And in this document, do you really actually need to state a date? Would it not be better just highlighting the fact that there's an action plan and you're working to the milestones in the action plan, which gives you a little bit of wiggle room? In terms of risk, you've got 2 real risks. You've got what I would refer to as the regulatory risk, which you refer to as the statutory risk, and you've also got the reputational risk. And both of those are very important, and both of those, I think, should be on the board framework. Now, we could argue about what the number is, but the fact that they should sit on the board framework rather than in the operational framework, I think is important. Thanks.
Thank you, Alex. Jean.
Yes, I actually lost some sound at one point when Bert was speaking, so apologies if this has already been covered, but I just wanted to make a wee point, which is that I'm very much hoping that as we promote the whistleblowing standards, that the assurance provided within the standards that to come forward must not result in negativity or detriment to anyone speaking out, will further encourage, will remove any anxiety and barriers, and further encourage speaking up where there are concerns around practice, culture, or any issues affecting patients, staff, or services. Thank you.
Margaret.
Thanks, Boyd. I just wanted to kind of say that I welcome the fact that the whistleblowing standards are kind of being discussed in tandem with the culture, and I understand obviously that that this is a component of the culture work that we're already undertaking, and I think that message is probably being given in the information that's gone out to staff so far, that link is made, but I'm just wondering about I mean, it comes back to this thing again about volume and complexity and just the sheer massive size of the task ahead, and the workforce associated with it. So it kind of links back to the culture discussion a bit, but it's that bit about the workforce model that we need in order to be able to implement all of this, including the whistleblowing standards, and the roles of the staff on the ground, the managers who will be supporting the implementation of this, the professional leads that will be supporting implementation of this, staff side, HR, and whether or not we've got a workforce model that we know, that we've consulted on, that gives us some kind of assurance that, you know, it's about timescales, it's about capacity, but what have we actually got in place in real terms, in terms of the workforce that is going to make all of this happen? So I suppose that's really my question for Fiona.
Thank you, Margaret. I think we must make that the last contribution. Ask Fiona to close this session off, as well as answering.
Okay, I'll try and be brief. So yeah, Alex, around the point of the 31st of July, I guess the aspiration there is that the outstanding actions will have been completed by the 31st of July. But as you say, the action plan is sort of an iterative document. So yes, it probably, I do like to set myself a challenge, but I think it is important that I suppose we aspire to do this as quickly as possible. And I think it is, as you say, it's important that any of those outstanding elements are covered off. I'd absolutely take the point around reputational risk, and I think this comes back to the discussion. There's almost a piece around it's a sort of the chicken and the egg, actually, that there is on the board framework, do we have a risk around regulatory risk and document what those particular risks are, and do we have, and we do currently, I think, have one around reputational risk around culture. So it might be that we just we can actually review and revisit those risks and make sure it's covered there, because it is absolutely it is both parts of that we need to cover off. With regard to Jean's point around you know, protection against detriment, absolutely, that is a core part of the standards, and it's something that I think, again, in terms of us being able to have the oversight role in place, not just of Bert as our independent whistleblowing champion, but also the role of the Guardian Service, again, because whilst they won't be investigating the concerns themselves, they will be tracking and monitoring our progress, and almost that is another element of our safety net. But it comes back to the cultural issue again, and of us promoting on an ongoing basis the fact that we welcome people speaking up, we encourage people to listen to what they're being told and to take action on it, and that's a good thing. So I think we just have to keep promoting that, and that's one of the reasons why our communications will go on for quite an extended period, which also kind of links me into Margaret's point around volume and complexity. Absolutely, there is a lot to do. I suppose ultimately a lot of these things, there's the delivery aspect or the project aspect of some of this, but actually culture and whistleblowing and raising concerns and managing people, it's all a core part of our leadership responsibilities. And so I think the key is about making sure that the workforce has the capacity to be able to absorb the key messages, and that our leaders have the capacity to understand their roles and to be able to carry them out and to be talking about these things. So I think for me, whilst the whistleblowing standards launch on the 1st of April, we need to be talking about this on a regular and ongoing basis as part of our broader kind of leadership and management support.
Thank you, Fiona. Thank all the contributors as well. We've been asked to consider this paper and the approach that's being proposed in it to implementation of the standards and consider the risks and issues. And I think we've done that in the course of our conversation. Can I take it that we are happy to approve that paper? Yes. Okay. I now have something of a dilemma. We're beyond our lunch break. My gut instinct, and I mean my gut instinct, tells me one thing, but I'm also conscious that Alex has got to leave us in the afternoon, and that he's one of the people who is going to contribute to the IFPR report. So I'm in the horns of a dilemma here as to which route to go. I would favour continuing with this item for a bit at least, and then having lunch. Are you content to soldier on? There's enough thumbs going up to suggest you are. Okay, thank you. So David, it's over to you to whiz through the IFPR, not to keep us too long from our lunch.
Yes, I'll be very conscious of that, everyone, and good afternoon. Colleagues will have a copy of the Integrated Finance Performance and Quality Report for February. It's important to note that this report goes through, and the board delegates a responsibility to the subcommittees of the board for primary governance and review of this report. And so it has gone through the relevant subcommittees of the board already. That's namely clinical governance, finance resources and performance, staff governance, as well as going through the governance routes of our health and social care partnerships. So we will take a more abbreviated look at the report and review of the report today, and I will ask in turn the executive leads for each of these committees just to talk about any highlights or escalations only as we go through those sections. So with that, if I can come to clinical governance, first of all, I'll come to Boyd Peters and then to Gaynor Roger.
Thanks, David. Board, Boyd Peters, Medical Director. Clinical Governance Committee is meeting 6 times a year. Meeting is usually about 2.5 hours long. Receives exception reports, and it also looks as a regular item now.
Your sound is breaking up, Boyd. Could I suggest, Boyd, that we go to Gaynor and Boyd, we're not hearing you.
Chair, I'm happy to intervene if needed.
Yeah, Ruth's just gone and told Boyd, so I think we just need to carry on until things recover there.
Yeah. Thank you again. That'd be good if you could. Take over.
Sorry, just to say that we have nothing to escalate from the Clinical Governance Committee who met earlier in March. Just really to note that our work plan and the agenda later today outlines the area of focus for the committee for this year. and to say that some of these are monitored by the Integrated Performance and Quality Report, as well as the committee having a deeper dive during committee meetings throughout the year. So I'm really just trying to show you that there's a big link between what we see in the Integrated Performance and Quality Report and our work plan. But nothing to escalate from the meeting this month. Thank you.
Thanks, Gaynor. Is Boyd able to rejoin us now?
It wouldn't appear so at the moment. Will we come back to clinical governance at a later point? With that?
Yeah.
Okay, if I can move to the Finance, Resources and Performance Committee, and as usual, there's two areas of focus. First of all, we'll look at performance. I'm going to come to Catherine, then Louise, then we'll look at finance and ask Dave Garden to make comment, and then we'll come to the chair, Alex, of that committee to make comment and further if any highlights or escalations. So firstly, if I can come to Catherine Sutton. Okay. Catherine, I don't know if you're on mute. Failing that, let me, while Catherine is sorting that out, we're not doing well here. Let's go to Louise. Louise, do you have anything to highlight or escalate for us?
Hiya, can everybody hear me? Yeah.
We can, yes.
Right, super. Just briefly again, because we know time's precious, just a couple of things to highlight. On page 114, 115, I think it's worth, on a positive note, noted the improving trend in our drug and alcohol timescales and interventions, which I think is a really good achievement, bearing in mind all the challenges we've had in recent times. Less of a positive at the minute is our CAMS and psychological therapies, which is somewhat on a downward trend, and it is an area of particular challenge for us. Our level of referrals has increased in recent times, and also our particular challenges around the 18-week waits and how we respond to that. We have now got the new programme board that's working hard to improve our position, and all four of the areas, so the two CAMS services, the two psychological therapies for North Highland and Argyll and Bute, have all got improvement plans in place. Scottish Government are working closely with us on those. But the good news part is that there has been some significant additional funding that has been identified by the Scottish Government for mental health as a whole, but with a particular focus on CAMS and psychological therapies. And we are just working closely with the Scottish Government in relation to the specifics of that, because we've got the headline for the whole of Scotland, but we don't know yet what that means for us. So that's work in progress, and hopefully that will start to see that real upward trajectory as we look at the short-term and the longer-term future of those two service areas.
Thanks, Louise. I see Catherine's back on. Catherine, can you hear us now?
Yeah, I'm back on. My apologies. I froze just at exactly the wrong point. So you'll see from the report that the position with our emergency department access targets across the acute site has been deteriorating over particularly December and January, and we're working very closely with both colleagues on the ground and within the hospital, but also across that wider system, to try to understand how we can unlock flow. And you'll note from the report that the majority of our obstacle in terms of our ED performance is wait for bed. So very much the support from the whole system response on that is ongoing, and a lot of detailed work is going on in relation to that. Other items just to note and perhaps to celebrate is that in terms of our response against new outpatient, we had pretty much performed to plan, and so that's something to note and to be cognizant of. and you'll see that in terms of our treatment time guarantee, largely we were in line with our plan, but over December and January that dropped off because of the resurgence of COVID. Excuse me. And finally, you'll see the cancer waiting times continue to be a challenge for us, particularly around our performance around urology and access to general surgery. And a recovery plan is being taken forward through our Cancer Performance Recovery Board. That's pretty much me, David, if that's okay. I'm happy to take any questions.
Thank you, Catherine. I should have also, before I come to Dave Garden and talk finance, can I just come to Joanna MacDonald with regards to our Gatland Butte?
Thank you very much, David. Thought you'd forgotten about me already. I'd like to highlight a couple of areas. So on page 96, I thought it was important to acknowledge the positive work to sustain improvements in reducing falls and pressure ulcers, which are a core part of our business, and just great to see that continuing. Also, in the interest of transparency, on page 99, you'll see around our complaints that we had significant improvement last summer. Unfortunately, a staff member moved on, so there has been a dip, but just for the board to be aware that this continues to be an area of high focus, particularly bearing in mind the culture conversation earlier on. And I think these were the two main areas, David, that I was wanting to highlight.
Thanks, Joanna. And to move on to finance then for this section, Dave Garden.
Thanks, David. I can be really brief. The paper shows the month 10 financial position and has a £3 million excuse me, underspend year to date. Looking to change that to break even once we get to the end of the year using IGB reserves. Just to update that the month 11 figures are available since the paper was being written, and that re-emphasises and confirms our estimate of break even by the end of the year. Still, capital position remains on track to deliver. People have been very, very busy, including having new robots installed and things. And we're still estimating we'll deliver our revenue and capital positions. I'll happily take any questions.
Thanks, David. If I can come now to Alex from the chair of the committee. Is there anything you'd like to highlight, Alex?
Yeah, thanks, David. Nothing to escalate. Highlight, yes. I think it's quite amazing the performance that we've had across the board in all sections, not just finance, but the performances in terms of the acute, in terms of mental health, and in Gatland Butte. I think we need to celebrate that now. In light of what we've done and what the teams have achieved, it's quite incredible. Yes, there are areas where the performance has dipped a bit. I actually think it would have dipped an awful lot, more because of COVID. So I think they've done well, and we should celebrate that now and thank the teams for all the work that they've done. Thank you.
Thank you, Alex, and I'm sure your comments are appreciated. If I can come to staff governance, and then I'll come back to Boyd Peters, who's joined me in my spacious office, you can see from the picture, and we'll cover the remaining parts of clinical governance. So if I can come to Fiona first of all, and then Sarah.
Yeah, thanks, David. And just to say, obviously, our single performance indicator currently is pretty static. I would just remind the board that from the next board, we will have an enhanced set of staff governance indicators that we're going to be adding to, so that we discussed that at the staff governance meeting in March. So I think we're on track to be able to provide an increased suite of data. And obviously, as we roll out things like the culture metrics tool, there'll be additional things even beyond that we can add in. But I think it's important for us to build out that data set.
Thanks, Fiona. And Sarah, anything more to add?
No, just to kind of follow up on that, we've been giving it a lot of thought, and we had some really helpful input from Kevin, who's been looking at workforce data. So we are giving that some careful consideration to make sure that whatever we add into the report adds some value in what the board is examining. Thanks.
Thank you. I'm going to ask Boyd to talk about clinical governance. You may not be able to see him, but you'll be able to hear him. So Boyd.
Thanks. I'm not sure what I said before I got cut off, but we're meeting 6 times in the year now. It's a reasonably length meeting, and the IPQR is a standing item with focus each meeting on different aspects of it. It's also the IPQR topics are in the work plan. There's also a plan to develop the headings that are within the clinical governance section. And so there's good examination and scrutiny and discussion of the topics that you see. Some of the work this year will include some work on the complaints and going back to some of the metrics in the sort of QPS side of things. So that's just a quick overview, and apologies that my tech and 4 different pieces of kit all crashed at the same time. So I'm grateful to David for putting me up for a moment in here with my mask.
Thanks, Boyd. I think it's just as before we open it up for questions, just to mention that with our remobilisation plan submission and indeed our plans going into next year, then the integrated quality and performance report will be refreshed so that it reflects that updated targets in some cases, as well as areas of focus. And again, the opportunity is for the relevant committees to help shape that and identify the relevant areas of focus that they believe is there and required, as well as what can be generated from a central point of view as the compilation of the report goes forward. So if I can leave it there, Chair, and open up for questions.
Thank you, David. Thank you for accommodating the other Boyd. Gaynor.
Thank you, Chair. This is in relation to the Ministerial Strategic Indicators on page 118. It was just to double check, when I've seen this at the IGB before, we were given an idea of what the targets were for these indicators. So I'm not sure what our targets are and what targets we've set ourselves in terms of this. And also, I'm just trying to get a feel for if the Argyll and Bute data reflects the activity where the patient flow is to Greater Glasgow and Clyde, or really in a sense, are we reporting in terms of activity in NHS Highland area, or are we reporting in sense of the activity if you're an NHS Highland resident? So I hope that makes sense.
Yeah. So firstly, some of the measurements don't have specific targets associated with them, or nationally associated targets. I think it is useful going forward that we should, whether we're creating targets, but at least being able to put what our benchmark performance has been, so that we can see the relevance of the number versus previous performance. So that is something we've already noted in being able to correct future iterations of the report. Secondly, in terms of Argyll and Bute numbers, and Joanna can correct me if I'm wrong, but it is in relation to about the treatment of residents within Highland, Argyll and Argyll and Bute. So if it's Argyll and Bute residents, it's the performance directly related to them, not to those who are resident in Glasgow, for example. But if treatment is provided by Glasgow, then it is the experience of Argyll and Bute residents who are treated in Glasgow. I think that's the easiest way to describe it. Hopefully that answers your question, Gaynor.
Does Joanna want to come in on that?
Just to say that certainly has been the case. I think it's interesting though, because it's a nuance. We almost double report, because we report our Highland residents to the NHS Highland board, but Greater Glasgow and Clyde also have their own waiting list, which will include the numbers of residents in Argyll and Bute. So I think that double counting, not double counting, but I think it's measured in both ways. But the clarity that we have here in Highland is that it's by the person's address where they live. So it is our Argyll and Bute residents.
Thanks, Joanna. Alistair and then Anne.
Yes, thank you, Boyd. I've got a question for Catherine, then probably a question for Dave Garden. Question to Catherine's around the cancer numbers. I noticed that we exceeded the plan for the period that we're being reported to for the urgent cases. Was that and it went through by over 20% as a variance? Is that due to catch up of people coming in during the lockdowns that happened? And if we get a bit more context around how comfortable do you feel that we actually are starting to meet all the targets on the cancer waiting times? And the question for Dave Gardens around the finance. It is great that we're projecting break even, but we sort of get some context as to around how much of that is down to the COVID, the COVID restrictions being placed upon us in terms of various things, whether that be for drugs or diagnosis or locums or whatever, and just some thoughts as to what the longer term horizon is looking like for next year. Thank you.
David, who wants to respond to that?
So Catherine, I think in the first instance.
Yeah, sure, no problem. So I think there were two questions for me. One was around us exceeding the plan that we had originally agreed to work to, and the second part was around how are we actually doing against our targets more generally in terms of cancer. So if I take the first one, what we've been doing, as I've mentioned now a couple of times, is we have set up a cancer performance recovery board that's a subgroup of the performance recovery board, and that has really been focusing on ensuring that we are getting our prioritisation of capacity correctly aligned to deliver to cancer patients and patients that are requiring urgent care. And that is being done through a clinical prioritisation framework, and also being led by Nick Abbott, who is our new cancer lead for the health board. I think that work has allowed us to identify patients earlier on that require treatment in terms of cancer services, and it's an evolving a new way of working that we've got going forward. And that has generated the discrepancy that we're looking at on the chart. But that's a positive thing, because it means that we've identified more patients and we've seen more patients and we've treated more patients than we might have been anticipating to do. That is using all of the capacity that we have available. So we haven't looked at, we haven't put a financial burden on ourselves. We haven't stressed our ITU teams and other areas. What we've been doing is reshaping the way we've been using our existing capacity on that. If I come to the targets, the Cancer Recovery Board is also looking at how we improve our target response. And we do have some work to do on that, particularly around urology. We have a significant capacity issue, and we are working with our neighbours in Dr. Gray's and have increased capacity in that area to try and mitigate some of our challenge around that. Pam mentioned in her opening statements to the board committee around the robot, and we're hopeful that increasing access to robotic operations will allow us to increase the delivery for cancer. That at the moment our patients need to go to Aberdeen, and they're prioritised alongside the regional resource for that operating capacity. We also have ongoing work to do to increase capacity for general surgery, and you'll have heard me talk previously around working with our rural general hospitals and opening up all that capacity, and working in a very different way across the one hospital, 4 sites model. So all of those things are targeted at us working towards improving our cancer position, but we are challenged, there's absolutely no doubt, Alistair, in terms of our performance on cancer, but it's something we are very much aware of, and we are tackling through a refreshed approach through this subgroup of the Performance Recovery Board.
Thanks, Catherine. And for the finance section, Dave Garden.
Thanks, David. So the first part around differentiating between COVID and non-COVID. But in terms of delivering break-even, board members will be aware that they covered the shortfall in savings that we didn't deliver due to COVID. So NHS Highland delivered 16 million out of a 24 million pounds PMO target, and that shortfall was covered with COVID fundings along with other boards in Scotland. And we did very well in terms of our savings delivery. And alongside that, they also covered anything that would have been deemed brokerage. So there's 8.8 million pounds of effectively underlying deficit was covered by government to allow us to break even. In terms of going beneath that, in terms of benefits from COVID and costs of COVID, it was really difficult to actually put numbers on the benefits, because the obvious things like prosthetics, because we weren't doing orthopaedic surgeries, it's easy to look at what cost reductions we've had in those areas. But things like staff travel and catering and all those kind of things, we had underspends materialising in the strangest places, but we also had additional expenditure going through from COVID. So it's been a bit of a spider's web to try and analyse the exact details of that one down to any kind of degree. What it did look like is that about £3 million of COVID underspends materialised that we hadn't been able to identify as part of the initial estimates, and we offset our COVID request by that amount in January, so that was taken off our funding. In terms of the longer term, well, we've been asked to submit a 1-year plan to government, recognising the current circumstances we're in. And the 1-year budget that we're submitting next year will be on a break-even budget basis, subject to receiving funding for COVID and remobilisation. The longer term really is subject to the work that Pam mentioned earlier on around reinvigorating the clinical care strategy to help inform what that cost of services are going to look like in years 2 and 3, to be honest with you. And I think government are looking for us to start to produce a 3-year plan at some stage during the next financial year, but not at this point in time. So a little bit of uncertainty in the future until we understand both funding and service delivery models. Hope that answers.
Thanks, David.
We have Anne waiting to ask a question.
Sorry, Boyd, I just suddenly somehow managed to flick my screen off there. So if I could just ask a point of detail and then a bit of a broader point, probably more to Pam. I was wondering if somebody could address the issue highlighted in the reports about our performance around antenatal services. But more broadly, I couldn't agree more with Alex's comments about how it has been a remarkable performance given the challenges of the year, and our thanks go to everyone for that. However, one of the things I was really struck with in the presentations this morning, first thing from our staff, were, I suppose, the comments around the potential of a third wave, the comments about how we're going to have to operate with significantly increased pressures, such as the additional PPE or infection control measures that reduce our capacity, etc., for possibly quite a long time to come. So I guess I was wondering whether there are any indications of the extent to which how we respond to that will be in our own hands as opposed to very much a national approach. We are still in an emergency footing. There were issues raised about how perhaps the extent to which we were asked to provide surge capacity for the first wave, was perhaps through hindsight not quite as effective as it might have been. So I'm just wondering, Pam, whether you feel that in our own remobilisation plan we've sufficiently allowed for the fact that this looks like a fairly long-term situation for us, albeit it might fluctuate. And secondly, how you see that balance in terms of national direction and local responsiveness. Thank you.
You want to come in, Pam?
Yep, I'll come in first and deal with that one, and then Heidi's sharing my room, so I'll let Heidi answer the antenatal performance question. I suppose the remobilisation plan, as it stands, in some aspects of service, so particularly elective, does require us to be able to operate, I guess, at the optimum level. And obviously each wave has interrupted that, so we haven't been able to stick to the plan, if you like. So that, I guess, that principle will still prevail. If we have a wave 3, we will probably have to make choices again, and that's not really somewhere anybody wants to go to, because of the what we see is the impact of what's happened so far. So it's set out in terms of us being able to step up again and being able to go at the capacity that we have determined locally that we believe we can do. But there is a big question nationally, probably with two parts to it. One is, the decompression aspect that we spoke about before. So where are staff and teams at? And therefore, how quickly can we step up in remobilisation, or how much do we have to think about that bit of space? And I think there's an element of that already begun, because things are slowing down a bit in terms of the COVID. But the other aspect is that nationally, I think there is recognition that there will be a need for a fresh approach. And so particularly around elective, there's an integrated planned care board that has now met twice, that has the remit of really starting to ask that kind of searching question of where are we going with this, and what's the potential actually at national, regional and local. So what's the balance in that of how we deal with the people that are on the end of that. And perhaps, under normal circumstances, would have had their surgery, or would have been seen in outpatients, or would have had their plan or their diagnostics done. So it's definitely going to be a blended approach. And I think we still are in a position where we will have to be agile in that, and absolutely be prepared that if we have to make a change again, that we know what we need to do. And I think we demonstrated on wave 2 that in terms of stepping up when another wave comes, we actually probably know how to do that now, and we know what we need, and we know how to treat. The bigger concern is that absolute elective aspect that is interrupted in that space. And then anecdotally, the other thing that we've seen, and I think others, maybe Boyd Peters might want to comment on this, is that the presentations, the acuity, the level of care and needs that older people coming into the hospital are presenting with is quite extensive. And we're just having a look at that and what the implications of that are in relation to how long they stay, how able we are to provide at home. It's just all kind of connected. So we're really trying to understand that. So a remobilisation plan, whilst it's got very clear targets, and that will remain something under very close review. And it may be that nationally there's a desire to take some different approaches if it can get to people quicker. So I think that's all stuff that we will work through. I can hand over to Heidi.
Yes, do you want me to?
It'll pick you up.
Oh, will it? Lovely. Just in terms of antenatal then, and I don't have the report in front of me, but certainly we're fully compliant with the antenatal targets. So 80% of women have their first antenatal appointment by week 12 of their pregnancy. A few meetings ago, we dipped under the target, and we looked at what was happening, and actually it was a data collection issue rather than us not actually meeting the target. So we're fully meeting the target, and as such we are ahead of many of the other Scottish boards. We're well above the Scottish average on this one.
Okay, thank you. Graham Hardy, and this must be the last contribution.
Thanks, Chair. It was just that we're mentioning Argyll and Bute in Greater Glasgow, and it's interesting, the Vale Leaving Hospital. I did a bit of research in the history of it. It was one of the first hospitals to be built after the inception of the NHS, and I constantly get asked questions in Helensburgh by my constituents on why they have to travel up to Paisley to get treatment. So I'm not too sure what the NHS Highland Board stance is on this, but is there any way we can improve services and influence Greater Glasgow Health Board with the Vale of Leaving? Thanks.
I think that will be one for David, first of all.
I think perhaps I would have come to Joanna, actually, Joanna, if you're still on the call.
Yeah, thank you. So the changes that have taken place date back to when Argyll and Clyde was responsible for services in Argyll and Bute. So they date back to 2006, and there's obviously we've got our contract with Glasgow. So the services we get from the Vale of Leaving or Paisley or wherever in Glasgow are all part of our commission with Glasgow. I know it's an area that comes up regularly, and it's probably more so or as much for the IGB as well to be considering this as NHS Highland Board around where the services are delivered. And certainly we've been exploring that as chief officers with Catherine and Louise around what services we could move back to Argyll and Bute and Highland and what that might look like. So I think it is fair to say, Graham, that it's an ongoing concern and an ongoing issue that I think particularly during the pandemic and the early days and months when we weren't to travel and we weren't travelling, that I know there was heightened anxiety about having to travel for some of the services. But I think it's probably worthy of a separate paper report and for the board and possibly for the IGB around this.
Okay, thanks, Joanna. Cheers then. Thank you.
Thanks, Joanna. And I don't see any other hands up at present, so conclude this item of business. We asked to review and discuss the performance outcomes, highlighting areas of concern. So I think we have done that, albeit galloping through it a bit today with David at the helm. So I would propose, if you're happy enough with the coverage of that item, that we go on, we have lunch and then we come back to have the Argyll and Bute initial budget office offer after lunch. I would suggest we break now and that we Zoom at 2 o'clock. Does that seem reasonable? 25-minute break?
Yep.
Okay, thanks.
Thanks, Blake. Thank you. Bye.
Thank you.
Thank you.
I'm paraphrasing, obviously. Oh, I'm in.
Okay, Fiskima, good afternoon. Here we go again. I think we're ready to resume, and fortified in different ways. We can move on to item 11 with the IJB initial offer, budget offer, and Dave to speak to the paper.
Thanks, Chairman. So the paper in front of you sets out the initial offer of a budget to the Argyll Bute IGB. We're required to do this in advance of the financial year. The context behind this is twofold. One is the IGB normally receives an NRAC share of the board's overall budget. That's a formula-based calculation looking at population and needs. And except last year, the IGB opted to invoke the government's decree that a minimum uplift would be applied to the IGB. So last year was the first year we've deviated from NRAC for quite a number of years. In the current financial year, as members are aware, we are hoping to submit a balanced budget to government tomorrow. We're finalising numbers right now. The initial submission we made to government was for a balanced budget for the first time in a number of years. In order to do that, we're required to phase our NRAC additional resources to Argyll Bute over 2 years. NHS Highland received £16.4 million in total of NRAC windfall in effect due to a change in the formula in the current year. And the proposal for this year is that this coming year is that that's phased in over 2 years to Argyll Bute, with them returning to full NRAC in 22-23. This has been discussed with the Chief Officer Joanna's here and Chief Finance Officer, and we also discussed it with the Argyll Bute Council at leadership meeting lately, and we're seeking the board to approve this. In addition, we're also recommending that in light of the phasing of NRAC over 2 years, that we don't require any repayment of brokerage for Argyll Bute for their share of the brokerage for last year, and that's £1.28 million, which will be absorbed by the board as part of its overall brokerage repayment schedule when it agrees that with government. I think that's all I really want to say. I'm happy to take any questions.
Okay, thank you, Dave. Any questions for Dave on the offer to Argyll Bute? Or any comments?
I wonder if Joanna's got anything to say, Chairman?
Yeah.
Yeah, just to add, as David said, so this has been fully discussed and agreed across the council with our council colleagues and with Dave, and I think that there's a real transparency around this as well. And I think for us as well, with our 3-year planning, which is an integral part of our report to the IGB, that to have that confidence for next year as well, I think is just really good. So so no, thank you, and thank you, Dave. I know it's been a significant amount of time as well, but I'm certainly pleased with the paper.
Thank you.
Thank you, Joanna. Are there any other contributions? Graham, Graham Bell, and then Sarah.
Yeah, just a quick question. Has been fairly new to this. So is this seen all round as a fair and equitable arrangement?
I think Joanna's nodding her head there, and I guess that's the key for me, that the IGB are signed up to this, recognising that if we did it any other way, NHS Highland wouldn't achieve its financial targets next year. So it's a compromise, which we're very grateful for IGB's cooperation.
Yeah, if I can just come in just to echo that, absolutely. I think the fair and transparent, it definitely is. So thank you.
Sarah.
Yeah, just to kind of follow up with an observation. Obviously, I haven't been involved in the kind of detail of this, but it was just to say I know that there's been a huge amount of work gone into this, both Dave and his team and Judy, who's our finance officer in the IJB, and all, you know, our council colleagues. There's been loads of work gone into this, and I know that there's been a fair amount of challenge as well. Obviously, everybody's always trying to make sure that they get the best for the organisation that they're representing, and I obviously witnessed that sort of as an observer in some of the meetings, and it was really good to see that challenge. But I think, but like Joanna and David said, it was really transparent, and I think where we've ended on this it actually really feels like partnership working. You know that balance of challenge and compromise, and it feels really good. So yeah, that was just an observation, and it was good to see.
And I can endorse that from having participated in the Joint Leadership Committee discussions around this. There was compromise on both sides. In that case, we've been asked to reach a decision on it, to approve the budget offer and agree to the approach recommended in the paper regarding the brokerage repayment. Are we happy to do so?
Agreed.
Agreed. Okay, thank you. And we move on now to the revised item 12 of the revised Highland Partnership Integration Scheme. We have a lot of paper for work for this particular item, some of it very colour coded, and we discussed that previously. That was a very helpful approach that the team had taken to that. And I'm going to ask David Park to introduce this item and to invite questions thereafter.
Thank you, Chair. The partnership agreements or integration schemes of integration are required to be reviewed every 5 years, and that's a national requirement for all integration authorities. The agreement was due to expire during the height of COVID, and there was extension again to this point. The document has been rewritten. Previously, we had 2 different documents that covered our scheme of integration. One was the partnership agreement going back to 2012. Subsequently, the scheme of integration was updated nationally and again adopted locally in 2015. What we have sought to do with this document is a fairly major rewrite, recognising that a lot of what was contained within the partnership agreement was historical in nature at the point of integration and involved a lot of information in relation to transfer and so on. But the material items of update are summarised in the SBAR, as well as highlighted within the report itself. It's fair to say that Section 6, with regard to the financial arrangements, was taken with particular scrutiny in terms of the review, and the document has been updated to give clarity in how funding arrangements will be agreed between the parties going forward. Clear escalation routes when there is variation in terms of both spend to budget, and a joint commitment between the organisations to transformation and efficiency, with a sharing of financial risk in association with that. I'd just like to say a great deal of thanks to many people who have been involved in this review, both clinically, financially and practically. In particular, I'd just like to mention Gillian Grant, Margaret Forrest, who are both mentioned in the paper, as well as Fiona Malcolm and others within Highland Council, who have been an integral part of this review. So the ask of the board is that they would agree in principle to this document. Thereafter, it would be subject to a period of consultation. Depending on the feedback of the consultation, then the authorities would be delegated, or the authority rather would be delegated to respective chief executives, to both Highland Council and in this case to Pam from an NHS Highland point of view, to approve any variation that would come back based on that consultation. Just to mention that this document has been taken to Highland Council and was approved at their council meeting on the 25th of March. Thank you.
Thank you, David. Do any colleagues of David's wish to come in? Okay, Dave Garden.
Silence always drags somebody at the front, doesn't it? I just endorse everything that David said. I think what this gives us from a financial perspective going into next year is a degree of certainty and surety, in that we've got a risk agreement around the savings target that we have now at social care. We have a joint PMO approach to with council in terms of delivering that savings, and we've got a clear understanding of what the baseline is and what funding is associated within the overall scheme. So it gives us that bit more certainty. Accepting it's a one-year agreement, it certainly should allow next year to be a lot less turbulent in terms of finances.
Okay, Pam.
I think Anne maybe had her hand up first. I don't know if she wants. Sorry.
Okay, Anne first.
Okay, so I'd just like to echo David's comments about how much work has been involved in getting us to this place, and add my own thanks to all those who've been involved, both in our own organisation and in the council, because it's been a lot of work, and we've been trying to get to this place for a long time. So thank you, congratulations, and it's great to be here. Just on the other side of the coin, I think we have to acknowledge that this is a first step, and that at the moment, some of the most difficult discussions that we have with the council around money will be happening on an annual basis. And I'd like some assurance, I suppose, from the team that we will quickly, well, not immediately, but that we do have a planned timetable in place for being able to start the discussions about next year at a suitable point, because I think it's likely that those will be quite difficult. And also, as Alistair pointed out to us recently, there's the local government elections, which will affect the council's timetable. So I think we just need to bear that in mind. So, and I think it's, it's, whilst it's great that we've got really good and improved relationships with the council, both at this level, but also, really working well through COVID and everything. It is going to be a challenge because the arrangement that we've put in place and the target that we've got for savings this year will be challenging. And I think we've yet to have some of the really difficult discussions in our joint project board that will be involved in meeting that target. And the other thing I just wanted to ask was, for some time we have found it difficult to, I suppose, update and develop our approach to our having a strategic view of commissioning our services in partnership with the council because of the difficulties we've had with coming to an agreement in finance. And I wanted to ask David if he thought that when finally agreed, this document will be a platform for moving that discussion on, along with obviously the work in the joint project board, and whether we see that happening in tandem with the development of our own clinical care strategy. Thank you.
Thanks, Anne. David, do you want to come back on Anne's question? Or good,
Yeah, certainly. In terms of the schedule for next year, and that is laid out in the document in terms of the timescales, both in terms of when those discussions would start and the timings associated with responsiveness and so on. And I think you're quite right to point that out, that that's going to be an important element, not only to build on the arrangements we have for this year, but to be able to adequately plan going into the following year. I don't think it will be any secret to know that the financial challenges that will be shared across both health boards and councils, I would imagine, going forward in the post-COVID aftermath are going to be quite high, and so therefore being able to work together with the council as we approach this is going to be so important. I think you've mentioned about strategy, and I think that's going to be a key element to the context of agreeing financial arrangements for next year and going forward, so that we are signing up to both deliverables as well as the associated resources that would go alongside that. And I think, as you rightly point out, that has been an area that has been missing in the conversation up to now. I think a document like this can only set a context for further relationships and discussion. It can't create them and it can't make them. But I do believe that the document gives us the platform to be able to continue that discussion with council, and it will be tested, I'm sure. But I think this gives us a very good platform to take that forward.
Thank you, David. Pam.
Yeah, I think Anne's question and David's answers have probably covered everything that I was going to say, other than just to add that the importance of this, the content of this document, and that we live it, I suppose, and the fact that the conversations around the budget can't stop. Indeed, we've got one tomorrow morning. We've got weekly and weekly meetings and monthly monitoring built in, and tomorrow mornings is absolutely right on to a continuation of the conversation we've been having. So hopefully that gives a bit of assurance.
Thank you, Pam. Gillian.
Thank you, Chair. I just wanted to come in just to add a bit of detail around that, the approach to the assurance. So what will sit alongside this integration scheme is the implementation actions around it. So you'll note within the document there are many actions, finance related and otherwise. So they have all been captured and will be put into an implementation plan programme. So there's visibility over every single thing that we need to be actioning to make sure that there's very clear oversight of that. So that's very much the focus of the next few weeks or so, to make sure that we've got that in a shape and the structures around it. Thank you.
Thank you, Gillian, and thank you for your considerable part in all of this operation. And a vote of thanks to David and Dave and all who are involved in these negotiations, not forgetting Anne herself and Alex, who were the non-execs involved from our side, and a huge amount of work, as you can see laid out before you in the papers. A massive amount of work has gone in, and that's just a tip of the iceberg, really, of all the meetings that have been held in this past year, particularly, to get us to this juncture where we have an agreement for one, albeit for 1 year, but we always saw this as a 3-year programme of activity. And I'm now going to ask if you're happy with the recommendations in the report, the agreement, that the report, the integration scheme can go out for consultation in principle. Maybe there are some amendments I would wish to raise, very small tweaks here and there, just to typing things, David, and also consider delegating to the Chief Executive in consultation with the Chair and Vice Chair any further amendments in relation to the scheme that may be considered appropriate after the conclusion of the period of consultation, which is set out for you in the SBAR. David, you wanted to come in?
Just a point of clarification. The 1 year agreement relates to the financial agreement only, but this scheme of integration is a live document as the backdrop to future years also. So just that point of clarification.
Yes, indeed. So are you happy to accept the recommendation in the report? Yeah, okay, thank you.
Thank you.
Move on. Thank you, David. We move on to item 13, which is the annual performance report of the Highland Health and Social Care Partnership. And I invite Louise to speak to the paper.
Yeah, thank you, Boyd. Okay, this is the annual report for 1920, which in current terms with COVID seems an age ago, and certainly you'll find from the report that there's a small reference to COVID because very much it was in its infancy at the beginning of 1920. So the reason it is later coming to the table really is because we did get special dispensation because of COVID, albeit as is slightly later than the Argyll and Bute one, which came last time. One of our particular challenges for that has been around data and getting the data in time to achieve everything. And you will see there are still some national data that we weren't able to put in because we hadn't yet received it. In the report, there's 9 adult social care outcomes and 2 children's outcomes. There's information on finance and also our future development opportunities and needs. It very much sets the scene at a certain time in place, and certainly the conversations that we've had in the Health and Social Care Committee and Anne and I have been involved in is that we really need a refresh of what we're looking at within this annual report moving forward. And we have been doing some work within the development sessions of the committee to look at what that should look like, and we've got a follow-up about that in June. So this is very much work in progress for future proofing what we need to be reporting on. One of our other challenges has also been about getting the report to the table. It isn't in the form we'd like it to be, and certainly we want it to have a much different look for the next year. So the next one's due officially later in the year now. We've got dispensation again, but we are still going to try and work for that June deadline so that we can get it to where we want it to be, because we want it to tell much more of a meaningful story really than I think we've been able to do up to now. It's probably fair to say, albeit it does show indicators that have shown some maintaining of performance at that point in time. Some areas that we were above average, some areas that we needed to improve upon, and we don't want to lose that from 1920, but we're conscious that it is a remarkably long time ago in all of our lives at the moment. I think that's probably all I wanted to say, but I'm more than happy to take any questions. I don't know if Anne wants to add anything more from the report.
Well, I think you've covered the main points, Louise, and just to add to that, obviously, given how life has changed since this period, it can't be said that the information here is necessarily indicative of current performance, of course. But I think the most important thing is that the committee is actively reviewing this, and the background or the opportunity to do that in a comprehensive way is now with us, with the fact that we're hopefully just about concluded the new integration agreement, because that includes a commitment to review the performance frameworks for both children's and adult services. So that gives us a real opportunity, as that framework really hasn't been comprehensively reviewed since the partnership was first agreed. So, and I think in previous boards, we've identified that, for example, the indicators around staff well-being and staffing issues are not what we would want them to be, similarly to our current performance report for the board as a whole. So I think, and just to add some support and a plea, I suppose, for Louise and the work that will be required to review the framework and to improve the report going forward, I think is really, it's understandable that TTG, waiting lists, acute performance tends to take up an awful lot of our planning and analytical resource. And now, of course, we have vaccination on top of that, as an additional call on our resources. But I think if we want to really put our organisation behind that strategy, or rather that strategic direction that we agreed earlier in the meeting, we have to really reconsider the resource that we put into both the collection of data around community resources and the analytical effort that we can put into assessing that data and using it to learn and to improve. Thanks.
Thanks, Alan. Are there any questions or contributions for Louise? Alistair?
Yeah, thank you. I note there's a few of the statistics, Louise, that still need to be done. So will this report be reissued again when we've got that data? Because it seems a shame that, we've got this annual report and then I think it's, on some of them, there is just not the data available yet because of the delay in COVID. I'm thinking around some of the self-directed support data, which I was quite interested in, especially. So is there going to be a reissue of this, do you think, at some point in the future?
I'm not convinced whether we're actually accurately going to get some of that data. So I suspect that is going to be tricky. Certainly that's the message I've been given up to now, that I'm not convinced we're going to get a whole system data for that year. We will endeavour to, and if it does come, then we will, yeah, absolutely, we'll update the report.
Pam?
Yeah, I think given that this is a point in time that's quite a lag now, actually the focus of that performance and the data that would be probably of more interest would be to, as we go through the kind of transformation and look at what's possible, will be to see what the performance is now and what that data looks like against the resource allocated. So whilst you might not see it in this report, the same relevant information will be required for the work that we'll be doing. So hopefully you'll see it in a different way, or in a more up-to-date way.
Thank you, Pam. There's a lot of fascinating information in the paper, albeit that it's for the previous year, around adult protection, guardianships, fostering, adoption, etc. And it would be good to have the up-to-date picture, and I don't have the time to understand why there's been such a change in the adult protection referrals, for instance, the pattern of referrals. Any further contributions? We're happy to approve the report presented by Louise. Yeah, okay, thank you, colleagues. And we move on now to Tim and to the Equalities, Outcomes and Mainstreaming report.
Thank you, Chair. This Equalities report comes as part of the public sector equality duty and the board's response to that. And we have a legal obligation to produce the report and to contain 3 elements. One is progress on fulfilling the public sector equality duty. Then there is setting out what our equality outcomes are. And then thirdly, there's presentation of employee information. The Argyll and Bute IJB also has the same duty, but as it isn't an employing organisation, its duties are slightly different, and the NHS Highland report covers Argyll and Bute as well. Work to develop the new outcomes and to report on progress has been carried out by or led by Helen Sikora, and she is attending the board this afternoon and can answer any detailed questions. It has been quite hard to develop the response and the new outcomes over the past year, particularly from a consultation point of view, given the impact of COVID. But 3 outcomes have been set out. There's certainly scope for modification, development, further consultation. So they're certainly not immutable. They're covered on page 340 of the papers and relate to mental health and well-being, freedom from violence and abuse, and control, people having control over their own care, and that needs to be seen in the context of equality and protected characteristics. It's worth bearing in mind, though, in terms of the setting of the paper, that equalities sits within the larger health and well-being agenda, and that in order to improve people's health and well-being, it really is essential to approach equalities, and the people who tend to have the worst health also tend to be those who the equalities agenda is concerned with. It also relates to the wider health inequalities agenda. In the paper is mentioned the social mitigation strategy for COVID.
I think Tim has frozen again. I wonder if Helen wishes to come in at this point. Oh, Tim's back on.
I'm back. I am sorry. Sorry, Boyd. It's
connectivity issues.
Yeah, sorry. I'm not sure what the last piece that you managed to get from me, but I was just saying that that the equalities agenda relates to the wider health inequalities agenda and to social mitigation from COVID. The social mitigation strategy was going to come to this board, but it will instead be going to the board in May. Progress on the equality outcomes for the past plan is on page 344 in Annex 1, and then Annex 2 contains information about employment. So I'm happy to take any questions, and specific questions would probably best be answered by Helen.
Okay. Does Helen want to come in just now? Helen, to comment further?
Hi Boyd, can you hear me?
Yes, yes.
Hi. Just to echo what Tim has said really in terms of introducing the report, and just to emphasise as well the partnership approach that we're taking to the equality outcomes. So I know Tim mentioned in terms of Argyll and Bute, but just further to that, I've been having monthly meetings with the equalities leads in both Argyll and Bute Council, within the IJB, and also been linking in with my colleagues in the Highland Council as well. We're really keen to have a consistent approach to equality and diversity across the whole of the NHS Highland area. So again, like Tim said, if there's any questions, I'll be very happy to answer those.
Okay, thank you, Helen. We have Graham Hardy and then Susan.
Thanks, Tim. Thanks, Helen. Yeah, I read the report with interest, and especially the outcome on mental health and well-being. And I was just wondering, I know we had this discussion with you, Tim, in my introduction, like often being diagnosed with a mental health problem can reduce your equality in the sense that you have a shorter life expectancy, you might be a life on benefits, discrimination in the workforce. So I was wondering how, the public health, how we might address this issue. Thanks.
Thanks very much, Graham. There is quite a big work stream on public mental health, which is actually getting larger and better resourced because we're able to put some of the additional public health resource coming in from Scottish Government into public mental health. So there's a range of things that we're doing relating to at one end suicide prevention, but also around community health improvement. I think what one thing that we will see very specifically, and unfortunately it wasn't able to come to the board today, is social mitigation in mental health relating to COVID, because there's an awful lot of mental health effects of COVID over the past year, and they'll continue for some time. So we'll have more of a detail in the paper coming in May about how we're looking to address that. So it's multifaceted. Everyone's got mental health needs, just like they've got physical health needs, and it's that gradation all the way from sort of general well-being to people with serious and enduring mental health issues. But one of the things about this particular paper is the importance of emphasising mental health as one of the outcomes. So I think you can see it in both ways: the importance of mental health generally, but also the importance of mental health in the context of protected characteristics.
Okay, Tim, thank you.
Susan.
Thank you, Chair, and thank you for this report. Very interesting reading. It made me make a connection back to something Pam had said earlier about the need to be tolerant of and embracing of difference, and this is one of the ways in which we can do that. We can capture that in some way. A more specific point, that there was a couple of places in the report where we referenced training and people accessing training opportunities, and I wonder if you could orientate us to the figures, because I can't tell whether 400 people turning up is a really good participation or not.
Yeah, I think it is particularly difficult in the COVID context to look at numbers, and perhaps we'll be able to see how that works in the next year or so. But specifically around the training, I think Helen may want to come back, and I think Fiona wants to comment as well, and may also specifically be able to comment on the training.
Okay, Helen, do you want to respond?
Yeah, thanks, Boyd. Just in terms of the training, I guess there's two aspects to that. So every health and social care member of staff has to complete equality and diversity training as part of their induction, and refresh that every 3 years. So there's that side of it, and there's a really high rate now of staff completing that training. Then there's also additional training we offer. So I guess in light of the pandemic and resources being deployed elsewhere, that's been a bit more tricky the past year. But we're very keen now to look at how we can provide those opportunities a little bit differently. So I'm trying to work on more kind of bite-sized sessions on topic areas. So example, online bite-sized sessions in terms of equality impact assessment, discrimination, unconscious bias. So those types of things. So I think training, what we've delivered in the past, is going to be quite different to maybe what we will be delivering this year onwards. I guess in terms of the figures, it's like I said, there's been a high rate of completion of the mandatory training. It has been challenging, I think, to get especially more operational staff to come along to the full day course on equality training, the one that we run in partnership with the Highland Council. But I'm hoping with the new approach and the new bite-sized online resources, and of course we've got CHURAS now, which has got an equality and diversity zone. If we can start to promote that, then that will really help and upskill people and increase people's awareness around these issues.
Thank you, Helen. And Fiona, you were wanting to come in?
Yeah, and I suppose it was just to, I guess this ties really well back to our first presentation around the strategy and our objectives, because one of our key objectives in the people space, and particularly around the creating a great place to work, is all around being inclusive, and that's something that's a core strand of our kind of programme of work going forward. So I think there's some really good opportunities here. There was just a couple of things I just wanted to pull out as well. I suppose the report does highlight that getting some of the employee data around diversity is really challenging, because it's not everyone is comfortable, and getting the data on the system is usually at point of entry. I'm hopeful that one of the benefits of our culture metrics tool is that we'll have a different way of being able to collate when people are telling us about how they're feeling and how they're experiencing the organisation, that hopefully there is an opportunity for us to kind of gather some of this data as part of that, and to understand if there are particular colleague groups that are experiencing particular issues more or less, to help us understand. And the final thing I just wanted to mention, because in the timescale since we finalised the report and published it, we note on page 344 that we've maintained our engaged accreditation of Carer Positive. Actually, at the end of February, thanks to the hard work of Jennifer Campbell and others in the organisation, we've actually moved to established status in recognition of the work that has been done around unpaid carers and supporting them in the organisation.
Okay, thank you, Fiona. Jerry.
Thank you, Boyd. I really just wanted to say how comprehensive I found the report, and it was very, very straightforward to read, and something that's very dear to my heart. I was very pleased to see the reference in there to the invisible disabilities as well, and because not all disabilities are obviously visible, and that's something that's really quite important to me. So I heartily enjoyed the report, and thank you to the people who pulled it together.
Thank you, Jerry. Anne.
So yes, absolutely. Thanks to Helen and anybody else that's been involved in putting it together. That's a really interesting report, and you know, the outcomes certainly seem very relevant for the coming year, Helen. I was quite surprised that the S-bar was indicating that there were no financial implications arising from this work, especially given, you know, how prominent an issue we know inequality is in relation to the pandemic. I mean, I absolutely accept that the basis for change in a lot of this work is developing and implementing appropriate policies, but I would be interested to hear Tim or Pam's views on that point, and I would also be interested to hear from Helen or anybody else. You know, we've got a lot of data here about our workforce, accepting that there are issues and difficulties with that. I wondered if any of the patient experience information that we might have now or be looking to collect in the future is going to be able to help us assess you know, outcomes from this work, and I flag up any potential areas of discrimination. Thank you.
Chair, if I can just come in, because I wrote the phrase, so it's my responsibility for the phrase in the S bar rather than anybody else's. I did write it tried to write it carefully, in that I did say there are no direct financial implications for this work, because I think there's a bit of a difference between how the board wishes to commit a strategic direction rather than saying we will commit so much money to something. And I think there are financial implications, but it's quite in a way difficult to quantify them. We're setting objectives, we're setting priorities, and those priorities will take into account the equalities agenda if this is the way we focus that, and it will potentially change the way that the board focuses the large amount of whole money that it spends. So I think there are a lot of indirect financial implications for the work, but it's the way that we set the we set the priority. And it will be difficult to say, well, if we agree with these general priorities, it will cost a certain amount of money, as it would say setting up a very specific service.
Okay. Are there any further contributions?
Yeah, probably just building a little bit on what Tim's saying there. I suppose there's where we've got direct projects that we commission or decide to go ahead with, that'll be very easy to maybe pull out costs. I suppose the spirit of this is how it's embedded across everything as a normal way to consider your business. And it might be that as we do that, we do see some differentials in the cost depending on what it is what we're trying to do. But I think it's difficult to pull that out. But I guess the point is we don't know the size of the financial implication, but there are financial implications. But I think we will have to get in the way of really thinking about that and quantifying that. As we're doing anything, making any change or trying to embed something going forward.
Thank you, Pam. Don't see any other hands up. So before we conclude this, I do notice on page 35 that there's an Annex 3 that's a reference to the composition of the board and the gender imbalance in the board, so it's something that we have to be conscious of ourselves, and when there is a future recruitment, that we take that into consideration, although we are in the hands of the national approach to that, the Scottish Government approach in determining that. The recommendation then is to approve the quality outcomes and the mainstreaming report so that it can be published by the end of April to meet a legal requirement. Are we happy so to do? We are, and thank you to Tim and to Helen and colleagues for preparing it for us and speaking to it today. Thank you. Okay, we move on now to item 15, naming of new hospitals. Not sure, is Deb with us to speak to that particular topic?
Yes, I'm here. Can you hear me?
Yes.
I'm not sure that the camera on my laptop's working at the moment. I've had problems all morning, so hopefully you can hear me. I have two papers for the board today. I'm hoping that people have the time to read the papers. I know you've had an extremely busy board meeting today. I'll take them both separately if I can, because they're two separate issues. So starting with Badenoch and Strathspey, colleagues will understand the the detail behind the proposal that we're setting before the board today. The design and the build of this new hospital has been going on for some time, and within Badenoch and Strathspey we've had very, very good engagement with the public and community as a large. And as a consequence, discussions have been ongoing right from almost the get-go about what the new hospital will be and how it will impact on the public. So in a sense, we've right from a very early stage seen an identity emerging which has been embraced by the public and the community at large insofar as the name and the naming convention. And throughout the discussions that we've been having, we've been referring to Badenoch and Strathspey Community Hospital, and as a consequence, the views that have been taken by the people that we've been engaging with is that we should be making a recommendation to the board to call the new hospital the Badenoch and Strathspey Community Hospital. Moving on to Skye, Lochash, South West Ross. Board members will be aware of the challenges perhaps we've had over the last several years in terms of getting a level of consensus as we build both the business case and as we have been getting to the point at which we've gone to construction and are almost at the point where we have a building. So this proposal is really seeking a decision about the process rather than. Without going through the detail, I'll take members to page 2, which talks about the process itself. In terms of a long list of options for the naming of the new hospital has been identified, and will be using Facebook as a vehicle to engage with the public. It's expected to take around three weeks in order to get sort of views from the public. Following which we'll undertake a panel, which Boyd, I think you've agreed to chair the panel to shortlist the preferred name. Excuse me. So really this paper sort of sets out the process by which we wish to take the naming convention forward, and we'll be coming back to the board once that process has concluded with a preferred option for naming the new Skye Hospital. So I'm happy to take questions from colleagues.
So we have a clear recommendation in the first case of a name, and in the second one we have a process to agree to. Does anybody want to comment on the first one? I feel duty bound to bring Boyd Peters in here since he's played such a prominent part in this initiative. Boyd.
Well, thank you, Chair and other Boyd. It's quite a few years ago now, but that we had a really robust engagement process discussing with quite a few community groups in lots of evening meetings over a period of time, the options for names and taking suggestions, and then finalising by agreement what the best name was, which was designed to acknowledge the history and how two hospitals, one in Badenoch and one in Strathspey, were going to retire as the new one was built in the centre location in Aviemore. And I think it was a very, very good piece of work. Great deal of engagement from all walks of local society. And I'm very pleased that we've reached this official stage, and the next date hopefully will be the opening ceremony some weeks after the hospital's moved into later this year. So I'm very pleased to endorse the name proposed in the paper and through the process described.
Okay, then any other contributions on either element, the Aviemore one or the Skye one? Margaret.
Thanks, Boyd. It's really just a comment that it feels like there's a solution already there which can be rationalised by reflecting on
consultation that's happened in the last few years, and using a name that's essentially already being used. So I would just, you know, from a pragmatic point of view, want to put across the view that it seems like a really sensible name. It does what it says on the tin, and it seems to be agreed by the local people because they're essentially using it already. So, you know, I think it's almost like if it's not broken, don't try and fix it.
Thanks, Margaret. Don't see any other contributors, so I'm going to ask if you're happy with both proposals. Firstly, that the name Badenoch and Strathbay Community Hospital be applied to the new hospital in Aviemore, and that the process for agreeing on a name for the Sky, the hospital here in Broadford, that it will be as set out on page 2 there of that particular paper, or page 372 of your papers. Are you agreeable to both proposals? I think the thumbs are going up. Yeah. Okay, thank you. And thank you, Deb. Good to hear your voice again. And if you could pass on our thanks to Kenny and to Kenny Rogers and to Heather Cameron, who prepared these papers as well.
Will do. Thank you.
Thanks. Our next item is item 16, the annual board and committee work plans, and Ruth is going to speak to that.
Thank you, Boyd. Yes, so this report seeks the board's approval of the work programmes for the next financial year for both the board and the governance committees. The work plans cover a range of activities, including statutory reporting duties, regular items of business, and certain pieces of planned priority pieces of work. They also provide a basis for executive team members to deliver activity directly supporting the key priorities and risks through a structured approach. All your individual governance committees have had an opportunity to discuss and input and agree the work plans, and the whole suite are presented here for board approval. I've had notification that, in fact, the Health and Social Care Annual Performance Report will be reported to the board in November this year, or every effort will be made to do so. So we shall leave that in the November slot for 2021 rather than the March 22 slot. So they're presented there for your approval.
Does anybody have any comments or questions about them? Sarah, first of all, and then Gaynor.
Thank you. It's just to, if we could reflect or record the update to the staff governance standing agenda. So I think just due to timing, we might have just sort of misaligned on the papers being prepared, but we have agreed to add whistleblowing as a standing agenda item for staff governance. So we could just record that in the minute, please.
Thank you. Yes, in fact, I had a note of that, and thank you very much for that, Sarah. Yeah.
Gaynor and then Anne.
Thank you, Chair. So in my head, the work plans reflect, I guess, the areas of scrutiny and assurance over a year which fit in line with the committee's remits. So I guess I'm just saying, in bringing them here today to the committee, I think that's something that we should have in the back of our minds. In terms of that, I think that there are two items that it would be nice to see on all of the committee work plans, and that is that when we re-looked at our governance structure, we were going to be bringing the strategic risks, or bringing scrutiny and assurance around the strategic risks. We initially said in our remits quarterly. I think with the the committee meetings every 2 months, we can probably only do that 3 times per year with our strategic risks, but just it would be good to see them in the committee work plans. And also just a reminder that also in our remits, we we have to undertake a committee self-evaluation every year. And so my suggestion is, I guess, that the results of that evaluation probably come to each of the committees at the same time as the annual report and the planning for the work plan for the next round. Yeah, I think that's where I would see them sitting with each committee. But really nice to see these for the full year. This is the first year we've seen it for the full year. So I understand it's a work in progress. Thank you.
Thank you, Gaynor.
Thanks. I just wanted to suggest an additional item to be included at relevant points in the board's agenda, and that was a report on the development of our longer term strategy.
Certainly, yeah, I can include that, Anne.
Good point. Fiona.
Yeah, and as well, I just wanted to I guess echo some of Gaynor's points around the value of having these work plans. Obviously, as I say, we used them for the second half of last year, and certainly from a staff governance perspective, it was really helpful for us in terms of you know, kind of planning out our agendas. And obviously, I guess they are absolutely a working document, and they've really helped us in terms of setting the kind of committee agendas. And by their very nature, you know, sort of they tend to be more populated at the front end of the year than the back end of the year at the outset, other than things that appear on a regular basis. But certainly from a staff governance perspective, we've seen them as a very positive kind of transformation and allow us to be much more kind of planful in setting our agendas.
Okay, I think there's just a need to make sure that there's uniformity across the plans and the plans, that things like the code of governance or the terms of reference are covered in each of them, just to make sure that they're uniform in those ways. And such as risk register as well, that they appear in each of them.
Okay, I can include that for you. That's no problem, and I can share them with the board once we've refined them.
Yes, I think as Gaynor said, this is a work in progress, yeah. And we have to finesse it. With these thoughts in mind and Anne's point about adding the strategy, are you happy to approve the work plans? Yes. Okay. And we move on to a committee membership review, and it's back to you, Ruth, again.
It is, yeah, thank you. Well, this is a report outlining proposals to refresh the governance committee memberships and board appointments with effect from the 1st of April. The revisions are highlighted there in yellow. We've now got a full cohort of non-executive board members, and this is the first opportunity we've had to refresh the governance committee memberships and flesh them out as they are expected to be. The proposals are to be held in place until November, and the proposals currently give some of our newer board members an opportunity to become involved and contribute to some of the governance committees. And then in November, we will consider this position again and finalise the position from there on. The changes also mean that this will mean for some of our governance committees, you will now need to appoint new members to the position of vice chair. And this report also gives us an opportunity to formally confirm Jean's membership of the Staff Governance Committee and note that her position of the vice chair is confirmed at this moment.
And there's still a vacancy on the Argyll and Bute Planning Partnership, CPP. Sarah, do you want to come in?
Thanks, Boyd. Yeah, it was just to clarify that I haven't ever been a part of the community planning partnerships in Argyll and Bute. It runs on a slightly different model from the ones in Highland. So it's not something I have attended up until now. And I don't know what the arrangements are. I don't know how often they meet and things like that. I suppose I'm happy to do it at the moment. But I would need to see some details of those meetings unless one of my other Argyll and Bute colleagues wished to take up that post.
Can we perhaps just remit it to you, Sarah, to follow up on that after the meeting and to liaise with Ruth? Are there any other points? Adam, you wanted to come in.
Thanks, Boyd. Yeah, just with regard to a review in November, just to say that, as you know, I will be reaching the end of my term as employee director and non-exec at the beginning of October. So therefore, clearly I'm not going to be on the committees after that. So obviously that will need to be reviewed before November.
Thank you, Adam. Yeah, in fact, some of your memberships are statutory memberships, so your successor will naturally go on to some of those committees, but thanks for raising that as well.
When do you expect a successor to be nominated, Adam?
During the summer. I don't have a exact timescale yet.
And it has to be approved by the Cabinet Secretary as well.
Yes, indeed, yes.
Okay, thank you. We've had discussion of this in our other meetings. So I don't think we need to spend a lot of time in it. I would like to thank Anne, who's done a lot of work in tidying up loose ends, a lot of loose ends that were there before, and bringing us an overall coherent picture as we have presented to us today. Thank you, Anne. We're being asked to approve revised governance committee memberships as in Appendix 1, to note that the Audit and Finance and Resources and Performance Committees must appoint a Vice Chair from their memberships, confirm Jean's position as Vice Chair of Staff Governance, and that a further report will be submitted during the course of the year to take account of further changes down the line. Are we happy to approve that? Yep. Okay, thank you. And then the review of governance arrangements, item 18. You will recall that in the first wave of COVID, we were asked to stand down some of our committees to enable our executives to have more space and time to deal with the onset of the pandemic. And then post first wave, we agreed that we would revert to the previous normal governance arrangements. That was from the 1st of July. At the end of last year, we got a circular from Richard McCallum, I think it was, in the Scottish Government, asking us to be mindful of the situation regarding the calls that were being placed on our executives going forward in the second wave. And early in the year, at a meeting of the Chairs Group, we decided that we would suspend some of the meetings or defer some of the meetings to allow our executives to concentrate more on meeting the demands of the second wave. What we're being asked today is to consider the situation certainly for the next 3 months or so. How do we feel about the position in regard to the requirements that we place on the executive and I think I'll ask Pam just to respond in a moment to that one. We've talked in the past about governance light model, but what does that mean? And even when we stood down some of the committees, we retained the audit committee. We were advised that should be continued. So we are now in a position where we can, I think, determine how we want to organise the governance of this organisation for the next 3 months, bearing in mind that the second wave is diminishing, and happily, as we heard earlier today. So maybe ask Pam for her views in terms of the ask being made of execs.
Yeah, I think this experience has been very different from the first one, where I think we stood down a lot and were able to focus on the COVID response. I think we described this second wave as we would go light and simmer because there was still so much business going on. And I think when you look at the suite of papers that we've had to go through today, and I accept that maybe whether some of the size of them could be condensed, some of them are set out as they're set out, and that is required. A requirement of the format of some of these reports. But this first quarter is always a busy quarter for any board, and I don't think it's been any less so. So whilst we were advised to try and be light and to try and pull back on the things that we absolutely needed to do, many of the asks still absolutely needed us to do quite a lot of the business as usual. So I think it's very difficult to find that middle ground, and I have checked out with some colleagues in terms of other boards, and I think that's not been, we haven't had a unique experience in that. Whilst the desire, has been to pull back, I think we are looking to come out of this wave. Now, we don't know what the future completely holds, but we are now looking to come out of lockdown, and so I don't think we have a position at the moment where we could pull back, and I certainly feel we've actually delivered quite a lot of the requirements that we need for the organisation at this point. So I think it'd be very difficult to, I think having our agendas focused and the execs and the chairs to be really clear about what needs to be on the agenda would be a really good thing to continue, and asking that question, what's the key information that needs to be in the reports, so that we do just bring what's required and we don't go to a whole lot of extra work that perhaps isn't needed. So I think we've got big agenda items on the go, and we need to keep the governance around it.
Thanks, Pam. We have a helpful note. I have a helpful note here from Ruth, who has consulted other boards. Ruth, do you want to say a little bit about that and what you've discovered in contacting the other boards?
Yes, well, it's a slightly mixed picture, or it certainly has been a mixed picture up until very recently. In fact, some boards, similarly to us, carried on their full governance arrangements throughout, and probably no doubt the boards that were more affected by the activity to support the COVID, the lockdown and everything, they pulled back their governance arrangements quite significantly. So it has been quite a mixed picture, but from what I can see, those that have been working on a much pared back governance situation are starting to move into the position where they are resurrecting various things, and several of them are starting everything up either from more or less from June onwards. So they're obviously gearing up to go back to normal effectively.
Yeah, given where we're at and the fact that we haven't formally stood down committees in this second wave, I wonder if we can just adopt Pam's suggestion of simmering to summer, that we might just continue in full governance mode, full committees, but that we would ask chairs to be mindful of the load on execs and also the backlog that's been apparent in our business today as well, and that we do on occasions don't require necessarily to have written papers or voluminous papers, that we can have verbal reports and slimmed down papers. Although I do recognise that in some cases slimming down papers is actually takes time when you're working from a full document. Ruth?
Yeah, sorry, I just wanted to ask a question. If you were content to continue to hold your meetings through Teams like we have done over the recent past, if that's something you're content to carry on with. And
that's a pertinent point as well. See a few thumbs going up already. I don't think we're yet at the stage where we could consider face-to-face meetings. I think that's still a little time away. It would be lovely to get together in one room at some point, but I sense from colleagues that you're happy to continue with virtual meetings just now. Anne?
So I just wanted to take this opportunity, Boyd, to raise an issue that I've become quite conscious of recently, and I mean it's not directly related to meetings, but it is a governance issue, and I guess it just goes back to a number of our conversations today when we've recognised how that getting back to normal is probably something we're not going to do, if ever, and that we might have to make adjustments in how we would normally operate to take account of having to live with COVID for quite some time. And certainly I've become, I mean, while there's been lots of advantages, and we've got a number of board members who really appreciated the advantages of this virtual world that we're living in, I think it has changed some of our aspects of our roles as non-executives, particularly that interaction on the front line of services. And whilst we can still meet people virtually, it's not quite the same as actually being able to visit them in their place of work, meet them in their place of work. So I'm sure there are other aspects of, I suppose, governance as usual, if you want to call it that are going to be affected in the same way that we're going to be we're looking at longer term agile working strategy and things like that. So I think, I mean, this may be something that is discussed and addressed nationally as well. I'm sure there will be views nationally on these sorts of issues, but I just wanted to flag that up, as we're talking about it, and that at some point we might need to have a wider discussion about what governance as usual is going to be in the future. Thank you.
Maybe around July time that we might have a better understanding of what the future is going to be like in terms of the NHS in Scotland and the national picture, and as well as the local picture. Graham Hardy.
Just a quick note, Chair, on that point. I know certainly Argyll Butte Council have endorsed a hybrid model of meeting and governance, where after hopefully if COVID does kind of go on the back burner and things settle down a bit, then instead of going straight back to all committees, have adopted a hybrid model where you'd have a mixture of some committees meeting up and some committees online. So I don't know if that's something to think about. Thanks.
I think that's all part of what Anne was saying, that we need to think about and to review. It's maybe that we've got a little bit of time yet which to do that. I think if we, at present, I think we need to conclude that we're going to continue in a virtual mode with our board meetings and committee meetings, certainly till the summer, and maybe review this at the July meeting. Would you be agreeable to that? Yeah.
Yes. Yes.
Yes.
Okay, thank you. Moving on then to item 19, the governance and other committee assurance reports. And if we can go as quickly as possible, then this one, Gaynor for the first two on clinical governance.
Thank you, Boyd. So today I'd like to report formally back on our strategic risks that we looked at the committee in the March meeting. So on our strategic risk relating to clinical strategy and redesign, after discussion, the committee has agreed that moderate assurance should be given to the NHS board based on the updates provided and the evidence of activity moving in the right direction. So we recommend that the EDG review the very high risk level associated with that in light of our discussions. In terms of the strategic risk relating to public health and Brexit, the committee considered this risk and agreed high-level assurance could be given to the NHS board based on the update provided and the low level of remaining associated risk elements. So we would be recommending to EDG that this risk was looked at with a view to removing this from the strategic risk register. And then finally, in relation to, sorry, my page is a bit there. Our third strategic risk, again, in relation to public health with the COVID-19 pandemic and resurgence of influenza in the winter time. The committee has agreed that we received a high-level assurance that we could give to the board on the actions being taken to mitigate against this risk, but we recommend maintaining the existing risk level as very high given the current circumstances. And that's all I have to report back in terms of what happened at the committee. Everything else, including those updates, are in the minutes. I'm happy to take any questions. Thank you.
Thank you, Gaynor. So there's three matters there to do with the risks and to be addressed by EDG. Any questions? Okay, move on to Sarah, and I think there are three staff governance committee minutes, one of which we had seen in one form before. Sarah.
Thank you, Chair. Yeah, so assuming everybody's read the minutes, I guess my three big ticket items are the culture programme, statutory mandatory training and the whistleblowing standards. Nothing there will be a surprise, hopefully. We have discussed at staff governance the risks around Statman and whistleblowing, and that links into the conversation we had earlier about how do we frame that sort of broader strategic risk on compliance. So that is in hand. One thing that I just wanted to record, which ties into our COVID governance, is actually we tried to go a little bit light with staff governance, but then it quickly filled back up again. But because we had a lot of really important things to talk about, so that was good. I just wanted to actually give a massive thanks, because I think despite us being in the middle of a pandemic, we've had brilliant engagement at the staff governance committee meetings, brilliant attendance, brilliant discussion, and I just I'm really happy with that. So thank you.
Thank you, Sarah. Any questions for Sarah on staff governance? The next one is the Finance, Resources and Performance Committee. Alex is not with us today to answer this afternoon to answer questions or to bring us points. Is there anybody else from the committee that wants to bring any matters to our notice? Okay, we have the committee minutes to review anyway. Draft Audit Committee, Alistair.
Yes, thank you, Boyd. Just two things I'd like to draw to the board's attention. One is that there was an internal audit report on the IPQR, and it might be worth giving consideration by David Park and others if they want to actually include the recommendations for that internal audit just by way of update in the next IPQR, just to join the internal audit report up with the next report that comes to us. I don't think they're particularly onerous recommendations. And the other thing just to draw attention to is that we're coming to the year end tomorrow, and obviously the outstanding management action list will need to be addressed. I think there's an update being done around about the 10th of April, and it'd be good if the executive directors could actually make sure as many of these are closed off as possible, and perhaps even a status against them all, so that there's an answer for them all, that are the ones that are not completed. I think we've made great improvements on that, and I think if we can just continue the drive on it, it would be very useful as we go into the annual accounts process. Happy to answer any questions, Boyd.
Thanks, Alistair. Any points? Well, Alistair, you have a new lay member joining the committee as well shortly.
We do. Beginning of May, Stuart Sands will be rejoining us as the lay member, which will add a bit more expertise and a different perspective to the committee's deliberations.
Okay, Dave Arden.
That's quite just and people might remember Stuart Sands, if he was an internal auditor with us a number of years ago. I'm showing my length of time in this organisation now, so it'd be nice to see Stuart back.
Thanks for that relevant piece of information, Dave. The Highland Health and Social Care Committee, Anne.
I think the only thing would just be a little bit of explanation in relation to the issue about discussion of risks that Gaynor referred to earlier, and just to explain that the Highland Health and Social Care Committee doesn't have any strategic risks allocated to it at the moment, and in terms of our requirement to consider operational risks and whether those need to be escalated as strategic risks. We're still, well, the organisation is still in the process of adapting its risk register approach in line with the restructuring that's gone on between acute and community services. So that work was considerably impacted, I think, by COVID over recent months, and but will be, is ongoing, and the committee will have a report on that in due course. So it was just to explain why we haven't had any of those issues on our agenda. Thank you.
Thanks, Anne. Any questions for Anne? If not, we move on to the Area Clinical Forum. We have 2 minutes of meetings in January and March. Margaret.
Thanks, Boyd. The only thing I really wanted to mention was the meeting at the beginning of March, which you have the draft minutes for. We agreed a process to attract more interest from across professions, areas and different levels of staff in the organisation to join in the work of the advisory committee structure as it changes. So hoping to send out a communication to all staff through Ruth Fry, meeting with Ruth and then this week sometime to look at that, and also encouraging each advisory committee to produce a bite-sized bit of briefing, very brief briefing if you like, to demonstrate what they're discussing on their agendas. So We feel this could be quite an important part of the clinical contribution to changing the culture, just raising the profile of leadership opportunities, so not just representing on committees, obviously, but it's one option to encourage staff to step into leadership more generally, representing the professions, whether they're junior or senior staff. We want to make it as flexible as we can, and take a more nurturing approach in terms of developing leaders for the future, and helping staff to see leadership as an opportunity before they're at the stage of actually being in what we would label as a leadership role. So it's just hoping that it contributes to the change in culture.
Thank you, Margaret. Any questions for Margaret? If not, we can move to Sarah and the Argyll IJB of the 27th of January.
Nothing in particular to pick up from those minutes. Also, we're always a bit out of kilter. Our next meeting is tomorrow, so we're always on the wrong side of the board meeting to give an up-to-date piece of information. Obviously, tomorrow is significant. We, as well as looking at the culture update, we'll be looking at the budget. We're finishing the year in a better financial position than I think we could ever have hoped for, but there is still a significant challenge ahead. I just want to note, obviously, that we are sadly losing Joanna. Joanna's moving on to things new, and she will be sorely missed. And I also want to record thanks to Gaina and Boyd, who've been on the IJB, and very happy to be welcoming Graham and Susan going forward. I think feels like we're on the precipice of a lot of change, but it feels like we're starting from a good point at this year end. Happy to take any questions.
And you will be assuming the role of chair next month. Okay, any questions for Sarah? Gainer Pharmacy Practices Committee of October, a little while back.
Thank you, Chair. So an application for a new pharmacy in Newton Moor was considered by the committee on the 9th of October 2020, and we brought the decision to the board shortly thereafter, and where the committee unanimously agreed to grant permission for this new pharmacy. There were then appeals against this decision lodged by 2 of the appellants, totalling 6 grounds of appeal. I'm pleased to report that all 6 grounds of appeal were dismissed by the chair of the National Appeal Panel at the end of February 2021. Therefore, I can tell you today that the decision to grant the applicant permission to be included in the pharmaceutical list of the board to provide pharmaceutical services in new premises at Newton Moor by the Pharmacy Practices Committee has been upheld. Thank you.
That's good news, Gainer. Thank you for that, and thank you to yourself and Alistair for your continued membership of the Pharmacy Practices Committee. Any questions on any of these points? If not, we're coming to AOCB. I have one item of AOCB. Does anybody else have any items of AOCB that want to raise? And mine is a bittersweet one. Sarah has partially stolen my thunder on it. And that we do recognise that this is Joanna's last board meeting. She's departing for pastures new after this meeting, or at the end of this month at least. She's going off to work for the Scottish Government in an elevated role too, as Deputy Chief Social Worker for Scotland. And I'm sure she will be keeping a keen interest in our affairs from these hallowed quarters that she will now occupy. We're very pleased that she is making that transition for her own sake, and that also that in that role that she will be able to voice the needs and aspirations of our rural communities and our island communities, which she is very familiar with, and that she will be able to influenced national policy in that regard. Joanna joined NHS Highland in 2012. She worked as district manager in Lochaber until she moved to the position of director of adult social care, and then latterly in 2018 to the position she currently occupies as chief officer for Argyll and Bute IJB HSCP. Joanna has been a huge asset to the partnership, as Sarah has already recognised, and to NHS Highland throughout the whole of her time in the NHS Highland area. And we will miss her. We will miss her for several reasons: for her positivity, for her infectious nature, bubbly nature, for her energy, for her enthusiasm, cheerfulness, and for the colour she brings to our meetings. I would like to thank Joanna personally very much for her service and dedication to health and social care throughout the Highlands, and to thank her on behalf of the board, to wish her well in the future, to wish her all the best, and to admire the way she has conducted herself, sometimes in the face of adversity, in her role as Chief Operating Officer in the last few years.